Hi everyone. I'll be talking about how the study by Chan et al. Did or did not address the threats to internal validity that have just been discussed and presented to you. In terms of temporal ambiguity, the patients in the study were already in the ICU and they were already ventilated and probably had some underlying anxiety before the self-administered sedation experimental variable was introduced. However, baseline assessments were made of both patient anxiety and health prior to initiating the independent variable in order to be able to compare the results and make sure that it was actually this independent variable of self-administered sedation that preceded the outcome, which would be the change in level of patient anxiety or safety. In terms of selection, we've already spoken to you about the fact that randomization is really the most effective method to control confounding variation, and our study did do that. The patients were randomized between the experimental and control group. However, there was an imbalance in numbers with only 17 participants in the Precedex experimental group and 20 in the usual care control group. The researchers did analyze baseline characteristics of both the groups prior to introducing the independent variable, however, and so this showed that there was no statistically significant difference between the groups. Therefore, it was helping to control for not only selection, but mortality and attrition as well, because there was an equal likelihood of participants in either group leaving the study. One of the ways in which a threat to internal validity was not addressed is that the healthcare providers participating in the study were not randomly assigned and for safety were not blinded to which treatment the patients were receiving. So there is the possibility of some measure of self-selection bias in the healthcare provider assessment of patient safety. The study did not address whether the healthcare providers in the experimental and control group were similar or had any statistically significant differences between their baseline characteristics. In terms of history and maturation, these were pretty well controlled for just because of the short duration of the study. The maximum amount of time a patient could be enrolled and data was collected was 5 days. However, even in a short length of time, when receiving intensive medical care, it's possible for patients, and likely that patients are going through some significant changes in their underlying health, which could impact their safety and anxiety levels. And we didn't see this addressed in the analysis or discussion in this paper. In terms of testing and instrumentation, the study used consistent methods for measuring pre- and post-intervention anxiety levels, but it was a self-reported scale, so there's always a possibility of sensitization from the pre-test to the post-test, altering the way that people would respond. The same guidelines were used to evaluate patient safety in both groups before and after the intervention, and there were some quantitative objective measurements like heart rate and blood pressure. However, there were also some that were open for variation and more subjective, like healthcare provider evaluation of a patient's ability to understand the rationale for pushing their button, and a more general term of worsening respiratory status that didn't have quantitative parameters. So all these considerations, the study overall had good internal validity. The results showed, however, that there wasn't a statistically significant difference in anxiety levels between the self-administered sedation experimental group and the usual care control group. It did show, however, that self-administering sedation is as effective as controlling anxiety as the usual care. And furthermore, that patients were satisfied by their ability to administer their own medication and help to control their anxiety. Lastly, in terms of patient safety, the study showed that there were similar hemodynamic changes in both groups, and therefore that patient safety was not negatively affected by the self-administration of sedation. An interesting outcome was that there were actually 4 patients in the control group that did not self-administer sedation who experienced delirium, and none in the experimental group who experienced delirium. The researchers don't attribute this necessarily to the intervention, but it is an interesting finding that should be explored further, and a determination can be made whether Precedex in particular or just self-administering sedation is significant in its ability to reduce patient delirium in the ICU.